O'Toole. I'm the National Consultancy Lead at the Centre for Dementia Learning, and I'm really excited to host today's really important discussion on the vital role of allied health support for people living with dementia, and in particular today we'll be focusing on the role of speech pathology and occupational therapy. Just before we begin our discussion, I'd like to acknowledge the traditional owners of the lands on which we meet today, and I pay my respects to elders past and present and to our shared futures together. Quick little bit of housekeeping before we begin. Your cameras and microphones are turned off, though we would absolutely love to hear from you. Please use the Q&A box if you've got any questions and comments throughout the webinar. Our team will be monitoring the questions, and they may respond directly to you, or they may publish a question so everybody can see. Please, if you like the question, like it in the chat. Due to time constraints today, we won't be able to take any live questions, so we have a couple of questions that we've fitted in that some people have very kindly sent us earlier. We will select the 5 top questions that you ask in chat, and we'll get back to you with some answers. We'll feed those back to our panelists and get back to you with some responses to those. We've got a really fantastic panel lined up for us today. 2 Dementia Australia advocates, John and Scott. We'll introduce them in a couple of moments. We've got Kim Teresi, who's the Senior Advisor with Speech Pathology Australia, Christina Watt, who's the Professional Practice Advisor at Occupational Therapy Australia. We'll also be sharing some details of 2 really important new position statements that were developed in partnership between Dementia Australia, Speech Pathology Australia and Occupational Therapy Australia. And we'll highlight some links to those towards the end of the webinar. It's also my great pleasure to introduce Anita Hobson-Powell, who's the Australian Government Chief Allied Health Officer, and Anita has very kindly agreed to open our webinar today. Anita.
Thank you so much, and welcome everyone to come along to this webinar today. I'd also like to acknowledge the traditional custodians of the lands that we're all coming from today. I reside and work on the lands of the Gubbi Gubbi people, so I'd like to pay my respects to their elders past, present and emerging. Dementia Australia is focusing on working with the allied health industry to improve the awareness to consumers of the essential supporting role that allied health professionals can play with dementia patients. And this has culminated in the release of these 2 position statements that we're going to hear about today that, as Gary has mentioned, have been produced in combination with Speech Pathology Australia and Occupational Therapy Australia. Now, allied health professionals play an important role in the prevention and management of dementia. Now, there's no universal definition for who is an allied health professional. Worldwide, we are not consistent. But in my working definition, there are approximately 26 university-trained professionals that make up this definition of what allied health is in Australia. And we're here today to support and recognise the role that speech pathologists and OTs play with dementia patients, but I also wanted to acknowledge there's professions such as the dietitians, exercise physiologists, psychologists, music therapists, social workers, just to name a few, that also play an important role in supporting those who have dementia. Now, my maternal grandmother and father both lived with dementia, and I've seen how hard it is to lose a loved one to this disease. But more importantly, I've seen the impact of this disease has had on these individuals themselves, their ability to retain information, communicate, engage with family, friends, society, and more importantly, their ability to undertake daily living activities. And it is here that the allied health professionals can help and provide support. Now, we need a whole of system change to support people who are living with dementia and for their loved ones. Now, I was an exercise physiologist and my sister was a speech pathologist. So we did come from the privileged position of having health literacy and knowing the system. We were able to step in when other health professionals didn't understand how to modify their practices when treating and managing a dementia patient. We also had to professionally negotiate with aged care facilities for my grandmother and my father when they weren't getting enough exercise, or when their meals were not appropriate so they could swallow, or they were losing too much weight and needed a more calorie-dense diet. But we were having the knowledge and we knew who to go to talk to. But many people in the system themselves don't even know who to talk to, refer to, and get support. We don't provide people with this system navigator to point them in the right direction. And unfortunately, we do have those health professionals who are working in the system themselves not knowing who to send these people to. So having the NGOs such as Dementia Australia step in and take on this much needed role is greatly appreciated. And these resources that are coming out today are really a step in the right direction to supporting the patients and their loved ones. So thanks, Gary, for having me along. I'm very interested in hearing about the stories.
Thank you so much, Anita, and thank you for that great introduction. I'm surprised. I had no idea there were 26 different professional groups who call themselves allied health professionals, and they're the officially recognised.
And it's growing. Yes, yeah. I was going to say, you look back probably 15 years, there was only about 16, and yep, we've got more coming through. So I'm sure in the next 10 years we'll have more.
Excellent. Thank you very much, Anita. I'd like now just to introduce one of our Dementia Australia advocates, John. John's very kindly come along today to share some of his experiences. John, I wonder if you could just first off tell us a little bit about the type of dementia that you have been diagnosed with and when you were diagnosed.
Gary, thank you very much. Can I just say at the outset, thank you very much for allowing myself and Scott as dementia advocates to speak to the audience today.
Pleasure, John.
Glenna started to notice unusual concerns when I was in my early 50s, symptoms that were different to the way that I had been, issues with processing and communication, serious concerns about my driving and changes in my personality. I had to retire in my role as a school principal in 2008 when I was 57 with no diagnosis, primarily because I didn't fit the typical stereotype of what a person living with dementia looks like. I was a reasonably young, very fit male. In 2010, at the age of 59, I was diagnosed with what's called younger onset dementia. That means I was diagnosed for the audience under the age of 65. Now, this type of dementia is believed to be Alzheimer's disease of the familiar type, as my mum, 2 aunts and an uncle were all diagnosed in their late 50s and early 60s. Although there's nothing wrong with my vision, my neurologist diagnosed me with visual sensory challenges caused by dementia in 2016, and in 2017 with auditory sensory challenges. Now, the most recent changes that have occurred with me involve memory loss. So that's in a nutshell about my type of dementia and how it evolved.
Thanks, John. That's interesting that you were diagnosed so young in your time and have such a strong history in your family. I wonder, you very kindly have shared a couple of pictures of some of the modifications that you've made in your home. I'm just wondering if you wouldn't mind just telling us a little bit about how access to occupational therapy and some of those modifications in your home have made a difference to how you live your life every day.
I will do, Gary. Are the slides up?
They are indeed.
Okay, all right. For the modifications of both the bathroom in 2017 and the kitchen in 2024, we started with an OT assessment and incorporated what we call dementia enabling features with a focus on colour contrast, safety and accessibility. With the following strategies and design principles in place, I can independently and safely make my own breakfast and lunch and assist with dinner. To minimise barriers whilst maintaining my independence, This is about the kitchen I'm referring to now.
Mm-hmm.
To minimise barriers whilst maintaining my independence, current abilities and functionality, we not only personalise the modifications with regards to my specific symptoms of dementia and the emerging disabilities that impact vision and hearing, both now and possibly as I age. We also chose a colour scheme in the kitchen to reflect memories of places that we visited in our advocacy travels, both nationally and overseas, when we presented at conferences. For example, the pure white sands, the translucent water at the edge of the beach, through to the greens, emeralds and dark blues on the horizon, with wooden areas represented on doors, etc. The scattering of orange in fruit, a few travel souvenirs and recipe books represent the lichen on rocks. Such happy memories every day. We asked for a special line of sight shelf specifically measured to fit a few mugs, bowls for porridge, plates for lunch and cutlery for me to maintain independence, minimise my reliance on others and to reduce confusion or anxiety, having to search through various cupboards or drawers. The shelf above the microwave, which has a flat base, not a turntable, as I was getting frustrated trying to align the turntable and would fiddle, therefore creating the problem. The dishwasher was chosen because it's very quiet, therefore less auditory overload. I requested a lowered triangular bench top at the outer edge of the kitchen where if my mobility is affected, I can sit there and independently use a toaster or a jug to make breakfast or use my laptop. There are charging stations and power points. These wonderful natural lighting, there's wonderful natural lighting all morning in the kitchen, and the positioning of the artificial lights on the ceiling was considered so as to minimise shadows in the evening. The design of the separate hot and cold water taps are identical in both the kitchen and in the bathroom, at the vanity and in the shower. I repeatedly used to place hot saucepans on Leminex bench tops, so we selected the stainless steel stove bench area, which unfortunately doesn't have colour contrast, but it's safer. Likewise, the induction stove top is safer because I was constantly leaving the gas in the low, not off position, or the flame up high. I was confused about where off was. The wooden chopping board beside the side opening wall oven is again for safety, as I use it to place the hot roasting trays to reposition my grip. The vertical line of sight open section for the chopping boards is above the induction stove area. Now moving on to the bathroom, there's line of sight from the open living area to the toilet. I don't always get the messages in time due to cognitive processing to allow enough time to get to the toilet, but this minimises wondering where the door opens to the accessible and enabling bathroom as opposed to the separate toilet nearby. The accessible toilet is higher than a normal toilet, and there's an L-shaped grab rail. This model is easy to get up and down from, plus it's easy to clean as we age. Note the colour contrast seat and the flushing buttons, which actually have braille on the top of each half. So are excellent for someone with a vision impairment. Once again, there's a great natural lighting from the skylight and a sensor light for the evenings and a separate light switch that's turned on manually for the light above the mirrored cabinet, which is also to light in the shower cubicle. The light switches are positioned at a height for someone in a wheelchair. Also, the vanity basin is compliant for a wheelchair to fit underneath, and hence why the hand tail is positioned where it is. Thank you.
Thanks, John. Sorry, I forgot to unmute myself, didn't I? Look, John, thank you for sharing those really practical ideas. I do have to say that the choice of colours based on your holiday memories is something that's new to me, and I think it's such a brilliant idea. That was a great suggestion. And also, I really enjoyed your mention of the use and the importance of lots of natural light. So thanks for sharing those ideas and for sending those photos in, John. I'd like to now introduce Scott, who's another one of our Dementia Australia advocates. Scott, in one of the position statements, you mentioned that from your perspective, speech pathology and speech pathologists were rock stars. I just wonder if you could tell us a little bit about how speech pathology has supported you.
Yes, thanks, Gary, and hello to everyone. I think we were supposed to be on screen, so I had a couple of little aids that my rockstar speech pathologist has suggested, but anyway, I'll try and describe them through the process. Just a little bit to let you know what sort of dementia I have, because I think that might set some context. I have language primary progressive aphasia dementia. It's a logopenic type that was discovered about 5 years after I retired, and I've also got the privilege, I don't know whether it's a privilege, but of having corticobasal syndrome, which is a Parkinson's plus neurological progressive disease tied up with that tau protein that's playing around in my brain. Anyway, I think the reason I say that is because I'm not the normal person that has Alzheimer's dementia, and I think the reason I'm doing so well is because of my rock star speech pathologist. There's no doubt about that. You know, on a daily basis, I have struggled getting out words and understanding conversations, and I can't write anymore, but Penny's taught me, you know, how to use keyboard and technology differently, and use devices like EMST, strengthening devices where I was almost mute at one stage, and now I can use different tools to strengthen my breathing and things like that. So to say that they're anything but rock stars is probably an understatement. And I think that the privilege I have of working with them, and also with even people like the talented speech students at the University of Sydney that have helped me along the way, is just game changing for us. So I can't speak high enough. So I don't know whether I've answered the question, but because I had a little bit of a different script before, but it's not painful having a session with a speech pathologist like Penny. It's not like going to the dentist and having a tooth out. It's actually energizing, and I look forward to the sessions. It's hard work because we spend an hour, and she just wants to keep me talking for as long as I can. So she's a rock star, but the whole team is.
Look, thank you. Thank you so much for that, Scott. You indeed have answered the question, and we will come back to you a little bit later. And look, I apologise to all of our panellists and also to the audience. We did have a couple of technical issues at the beginning, so Scott and John are both speaking to us via their phones. What I'd like to do, moving on from Scott's comments, is to introduce one of the rock stars. So Kim is a speech pathologist with Speech Pathology Australia. Kim, I wonder if you can tell us a little bit about how speech pathology can help people diagnosed with dementia maintain communication abilities in particular and their quality of life in general. Both in the early stages of their dementia, but also as their disease progresses.
Thanks, Gary, and thanks, Scott. What an introduction. Wow. Well, speech pathologists use a variety of approaches to support across all different stages of dementia, as you've mentioned. And we work across two main areas. So we have expertise in both supporting communication and swallowing and eating and drinking. And I guess having effective communication and safe swallowing is a really vital part of our quality of life. But in terms of communication, communication is so core to who we are and essential to our identity. And being able to communicate means being able to tell people our needs, our thoughts, our feelings, our decisions, and being able to maintain connections. And we use a variety of different ways to do that. We might send a text, we might read an email, we might listen into the TV and process what they're saying, we might have a chat with a friend. So speech pathologists work across all those different areas of communication. And often dementia was sometimes thought about as being about difficulties with memory, but we know that communication and swallowing are skills that can be affected across the course of dementia, and for some people from very early on at diagnosis. So as speech pathologists, we're interested in effective communication. So how the person can get their message across and maintain those connections, not so much just about how you can say the word. We certainly use a reablement or a rehabilitation approach. There's lots of different words that are used sometimes, but essentially what we're referring to is finding a way to support the person to continue to do things that are important to them for as long as possible. So we're going to take an individualised approach and work with what that individual person needs, and use a strengths-based approach. So that means we want to know, as much about what's going well with cognitive and communication skills and be able to use those strengths to compensate for the areas that aren't going perhaps quite as well as they were. We'll use a range of different approaches. So for some people, we might do direct therapy sort of practice exercises on specific skills, maybe practicing word finding skills in a certain context. We often will use training of different strategies to compensate for difficulties. So for example, somebody who might have difficulty reading and understanding a longer recipe, for one person we might be seeing if using photos and simple words can help, and for another person we might be using their preserved strength of listening and understanding to auditory information to use a recorded version of the recipe instead. Speech pathologists prescribed communication aids, and they can be as simple as a simple communication card that I take down to the local cafe to order myself a coffee just the way I like it, right through to something more complex like communication apps on your phone or even electronic speech generating devices. So they're there to give the person another way to let the person know what they want to say. And speech pathologists make sure that it's just the right fit and type of aid for that person, because what works for one person doesn't necessarily work for another person. Communication partner training is a really core part of what we do as speech pathologists. That means we need to give tips and tools and strategies to the people around the person. So their family, their friends, their neighbours, their care staff, other health professionals, so that they can know what sort of strategies are going to make for successful communication for that person. We're providing education and group therapy programs. We might work on recommendations to make the environment more accessible, and of course, swallowing assessment and recommendations around safe swallowing. So we're going to adapt the focus and intervention as needs change. So, for example, we may work more extensively with the care partner at later stages to empower them to maintain communication, even if somebody's non-verbal. So we're working right from those early stages, including at the diagnostic process, right through to end-of-life care. And it's really important for people to be able to access speech pathology early, and so that they can learn and practice putting those strategies into place early. But it's not just the person with dementia, it's also their support network, because we know that communication is that two-way activity, and it relies on both the person and their support network. And so I'm going to ask Scott a question now. I know that you feel strongly about the importance of speech pathology, not just for the person, but also for family members and carers. I'm wondering if you can share with us a little bit more about how your speech pathologist has provided support to your wife, Jill, and other family members.
Yeah, thanks, Kim. I'm probably not going to give this justice, but I'll give it a go. Our speech pathologist team not only looks after me, but is a really valuable resource for Jill. And I might go one more and also say, also for the people around me. And I'll use my buddies as an example. And I know my golf buddies give me a hard time all the time, but they're, Penny's taught sort of Jill to coach them and to move me to the end of the table, because they were trying to put me in the middle of the table because they didn't want me left out of the conversation. But it's better for me to be at the end of the table, so I don't have multiple conversations and complexity. So that's one. They just want to support and make sure that the family unit operates properly. And this is another example where Penny came out to the home to see us and have lunch. And this is not the normal Zoom sessions. This is hey, she's pretty sneaky. She's coming out to make sure that the home environment and Jill and understanding how we operate, because that helps her help me, which is important. So I think that's another example. I think she also sort of helped us through navigating some future challenges or possible future challenges around swallowing. The advantage of doing research with the Frontier Centre gives me, because I volunteer, or a guinea pig, should I call them guinea pig? That's probably not the word. A guinea pig for research. I get the advantage of having access to, world-class speech swallowing people as well. I don't need it now, but it reassures Jill for the future. So I feel that our speech team partner us through the journey, if that makes sense. Because I don't get any free passes, but they all work together to make sure that I continue to speak for as long as I can. So, which is fantastic. But it's not just me. It's more you help the care partner and the people around you, the better it is for me. So I can be clearly selfish here. It helps me. So there you go.
Thanks for that, John. That's some really, really interesting advice. And I'd never thought about that idea. You spoke about not being placed in the middle of the table, which is where I'd probably want to put you so that you're surrounded by your friends and able to join in. But the overstimulation that creates in itself creates extra challenges. So look, thank you, Kim, and thank you, John. I'd like now to introduce Christina Wyatt. Christina is the Professional Practice Advisor at Occupational Therapy Australia. Thanks for coming along, Christina. I wonder, Christina, if you could tell us a little bit about the role of OT interventions and tailoring OT interventions or allied health, occupational therapy interventions, again, meeting those evolving needs of people living with dementia.
Thank you, Gary. Yes, I think maybe to start answering this question, it might be good to just clarify what an occupational therapist is, because I think there's a lot of confusion about what an occupational therapist does, and specifically how we might work with somebody living with dementia and their families and carers. As John and Scott have so eloquently explained, that's part of the process of us supporting people living with dementia, is to collaborate with all the sort of key and significant people in that journey. So I guess the most important part of what I think an occupational therapist does is we focus on the role of the individual to meet their everyday living goals. So if you are somebody who loves to be active and out and connecting with people, then that's an important and meaningful activity, or as we would say in our professional language, an occupation, hence the occupational therapy. And what we want to do then is think about not only the type of dementia a person might be diagnosed with, because as John and Scott have explained, there are features of different dementia presentations that will come out more strongly in the symptomology. But also we want to think about where the person's functional strengths still lie and how we can enhance or support that person's functional ability. Because as we know, if we don't support ongoing engagement or activity or participation, then people's functional performance will deteriorate and the symptomology of the dementia will exacerbate, and actually the trajectory of dementia can actually become more rapid. So we really are so focused on the abilities of that person and how we can continue to enhance or maintain those abilities. And we do that by understanding what's important to the individual. We're led by the person living with dementia and what is that they want to do, what's important and meaningful to them. We're led by their strengths and where their abilities exist. We're led by what's their value base and their beliefs and their own sort of intentions for life. And then we tailor our strategies to consider all those elements together. And it can be down to things like the beautiful examples that John gave earlier around his kitchen, modifications, you know, building in features that allow him to be sort of, I guess, reflected in his environment, to feel that the colours used are an example of his story, his journey. And not only is it about making sure that he can do the tasks that are important to him, so having that wonderful station that he showed in one of his photos of the kettle and the toaster and all those things needed to just make the daily task of breakfast or lunch preparation easier for John, but also that environment is an example of his values and interests, and that it's easy for him to be seen in his own environment, to be reflected by his activities meaning something for him, meaning something important to him. So we do a really tailored and very individualised approach. And to answer your question, what we then do is work collaboratively and alongside that person living with dementia to continually evolve those strategies, to continually consider where those strengths and those deficit balance areas begin and end, because as we know, this is a degenerative condition, and we unfortunately do see that functional decline is expected course in this diagnosis. So we will work then with those changes as they evolve, but never lose sight of what it is that the person wants to be able to do and how we can support them to continue to maintain those important occupations or activities that are give them their meaning and their purpose. And probably one of the main strategies that occupational therapists are recognised for is our acknowledgement of function. So we are really skilled at assessing and analysing functional performance, and we often adopt environmental strategies, so changing the environment, as you've seen in John's photos, bringing in assistive technology or equipment or devices to support people to continue to do the activities that are important to them, and then allows that evolution of function as things like memory changes or communication changes might start to become a barrier to people doing what's important for them. So I've got now a question for John, and it's aligned to the thinking around the occupational therapy role, which is looking at the use of digital technologies or assistive technologies. And I wanted to ask John if you could tell us about the ways in which digital or assistive technologies have assisted you in your activities of daily living, and in particular, how an occupational therapist might have supported you with that. And in relation to your driving, when you once were driving, how did that occupational therapist help you with that role? Because that's another element of our practice that's really fundamental in this space.
Thank you very much. That's a two-pronged question. So I'll answer the first question. That's related to the use of assistive technology.
Thanks,
yeah,
John.
Now you would have noticed one of the photos that was on the screen. On that bench, there was an appliance called a Thermomix. Now, some of you may have one of them if you're lucky. Dennis and I used to have an old model Thermomix. And because I love cooking, I try to use the Thermomix as a different way of making things from the recipes that were provided. However, I had difficulty with the recipe genre. As a solution, an OT suggested that Glenys rewrite my favourite recipes so as to integrate the ingredients with the methodology. Now, as you can imagine, that was time consuming, but it certainly assisted me and made the task more joyful, more enjoyable. Now we have a more recent model that has Wi-Fi connection and many more recipes included. And every recipe has integrated steps, including the ability to weigh ingredients during the cooking process. Now, because I have executive functioning issues, which involve organisational skills, to streamline the cooking process, Glenys has suggested that I have all the ingredients assembled in one location before proceeding with cooking. Now, I really enjoy using the Thermomix and take great satisfaction from the end product. Moreover, I feel a great sense of achievement, particularly after receiving positive feedback from those with whom I share my creations. My muffins, in particular, are savoured by many who have tasted them, and they're always asking me when am I going to prepare another batch. Thank you. Now, about the driving. Now, driving represents a form of independence for people. I no longer drive, and I haven't driven since 2014, but leading up to that period of time, I found that driving was becoming more difficult. Now, Glenys and I speak to students from a local high school about driving, and driving to a lot of people seems to be a simple task, but it's not. When broken up into its integral parts, it's quite complicated. More so when you have to make decisions regarding road rules and so on and so forth. Now, I get to the point where driving became such a problem that my GP insisted that I do a driving test to establish my driving proficiency and my cognitive awareness of the rules. Now, it was undertaken by a driving school instructor accompanied by an OT. Now, some people with dementia go out with a driving school instructor alone, and I don't think that's a valid way of testing your driving ability. So it was insisted I do it with a driving school instructor, and Glenys was the one who pushed the point that, John, you need to have someone else in the car who has the skills and the knowledge for driving behaviours, which is so important. Now, before I went out on the road, I did about an hour test with the OT, who used a computer program which tested my spatial awareness of a number of scenarios occurring on the screen. I was then asked to travel the distance of about 25 minutes from home along a route with which I often travelled. Now, the driving school instructor sat in the front passenger's seat and the OT observed me from the back. Now, after I completed the test, and I might say I completed it successfully as far as the OT was concerned, the OT recommended certain modifications or strategies that I should adopt whilst I continued driving. The first one was I was not to drive any longer than 30 minutes before resting. The OT had noticed that after this length of time, my concentration skills had diminished. And even though I could legally drive without my glasses, I was advised that I should wear them at all times whilst driving. I was not to have the radio on because the OT considered that was too much of a distraction. And I was not to have any passengers in the car. As I mentioned, I discontinued driving in 2014, and I surrendered my driver's licence into the Department of Transport. Thank you.
Thanks, John, and thanks, Christina. So, John, I'm sure at Dementia Australia we're not allowed to endorse branded products, but I think I might have to go out and get myself a Thermomix fairly soon. Sounds like a real.
Can I just mention? Yeah, sorry. I want to mention something. This is very important.
Please.
Now, one of our good friends who is a researcher at the Queensland University, her name is Dr. Teresa Scott. Now, she's done a lot of work, particularly with people with dementia who are having difficulty giving up their driver's licence. So she's developed what's called a transition program. I mean by that, they mean what are the strategies and mechanisms that can be put in place so the transition is smooth. And the name of the program is Car-Free Me. Thank you.
Thanks for sharing that. That's Car-Free Me. We'll have to have a look. Thanks for that. Just throwing back to Christina and to Kim, and I'll ask Kim first, but we asked our audience to pre-submit some questions before the webinar. And one of the common questions that we received was around the challenges that people face accessing allied health support, and I'm thinking both in community settings but also residential aged care if we've got time. So if I could just ask Kim, and then I'll get Christina to comment as well. What are some of the challenges that people face at the moment, and how could we make access more equitable? What can we do about that difficult situation?
Yes, well, certainly there have been a number of challenges for people to be able to access allied health. I think one of the first things for us all to think about, though, is stigma, and to think about what are our own beliefs and expectations around dementia. So often it's been thought that, oh, nothing can be done because there is no cure for dementia. And that sometimes has been something that's been thought about, you know, perhaps by referrers, doctors, health professionals themselves, and maybe even people living with dementia and their families themselves in terms of having an understanding of what they could possibly be supported with. And whilst, as we've said, dementia is a degenerative condition, and we do know that there will be functional changes over time, with access to reablement and allied health, people can be supported to maximise their participation and function and well-being for longer. So research shows that speech pathology can be effective in doing this, and it also shows that people living with dementia want to be able to access reablement from allied health. So we need to start off by challenging our own beliefs collectively. Reablement works, and I think that's led to often a lack of awareness of the role of allied health professionals such as speech pathologists and the benefits of dementia rehabilitation. And that's where it's such a wonderful opportunity for us to be here and having this opportunity to talk in the webinar today, but also to launch our joint position statements around speech pathology and occupational therapy. I think one of the main things I'll mention is the unclear pathway to be able to know where to go to get this support. It's been really difficult to navigate and for people to find these services, and that's exacerbated by the lack of appropriate funding mechanisms underpinning this service delivery, particularly in residential aged care. So it's very confusing for referrers, for people. Do I go to my GP and get a chronic disease management plan? Do I go to the local rehabilitation centres? Should I call my aged care? Should I go to NDIS? Where and how do I refer? And the answer is kind of all of the above, maybe, potentially, but that makes it quite confusing. So what I would say is we need a really, Anita mentioned at the start, a whole of service, whole of system sort of change here. We need a really clear post-diagnostic pathway that's really evident and automatic once somebody is provided at that time of diagnosis with this information. And we need that pathway to be funded to provide allied health services for people with dementia, wherever they live, whether that's at home or residential aged care. We need it signposted as a dementia rehabilitation pathway so that that awareness for both referrers and the community is there about its availability and applicability. I guess at the end of the day, rehabilitation is a right for people with dementia, and we really want it to be available for everyone. I'll hand over to Christina, perhaps.
Thanks, Chris. Thanks, Kim. Christina, I see you nodding furiously in the background. Have you got a couple of other comments you'd like to make?
Yeah, Kim's absolutely nailed it with that response. I think we acknowledge that there's so many parts of our health system that actually aren't designed to support people living with dementia, and we need to bring those services together and make it much easier for people to have access to those essential components of the health and allied health services. So what we also know, alongside what Kim mentioned with respect to difficulties with knowing who to go to, where to go to, referral pathways, all the rest of it, is that we also have a real disparity with the main funding programs and how they actually deliver their funding to people and how they allow people to use their funding to access allied health. And that makes it really hard for people who might be, wanting those services and definitely needing those services, as we said, to be delivered in a restorative and in a comprehensive way, to have access to them if the funding is, rationed, or if it's restricted, or if there's no clear expectation of that funding being used to support people with a restorative approach to their dementia needs. So we know that means that ultimately we end up with people having, I guess, an inequity to service access, depending on when they might be diagnosed with their dementia. So if you're, as John has shared, a younger onset dementia diagnosis and you're under 65, you may have access to the National Disability Insurance Scheme, and that funding program operates in a way where there's a more perhaps needs identified and tailored approach to accessing allied health services that could be delivered on a frequency and an intensity that would support the progression of a person's diagnosis. Whereas over 65s, if you're diagnosed in that patch of your life, then you're accessing the aged care system, and that is a system that is designed to be rationed and measured out and somewhat restricted in its availability for timely and intense allied health services, and therefore it doesn't often allow for that sort of level of input that we would want people to be getting at different points in their diagnosis. So we want to see a program and an approach that looks at a needs-based service delivery model where people are assessed at their moment in time of their diagnosis, and the care that's required and the services that are required are delivered to meet the identified needs in that moment, not based on what the funding program might be able to offer you or what might be available in your package, but what can be done to meet your needs in that exact moment.
Gary, I was nodding
Yes.
vigorously when I was listening to when I was listening to what Kim said, and also Christine. But can I just put my advocacy cap on now?
Mm-hmm. Please.
Although I was diagnosed with younger onset dementia, I was 62 when the NDIS was introduced into Australia, right?
Yep.
I was 65 and 6 months when it came into Queensland, so I missed out. So there's a postcode discrimination as far as services are concerned. And this is something that advocates like myself have been working tirelessly to change. Now, just because I was 6 months older than someone who was less than 65, does that mean my needs are different? No, they're exactly the same. Thank you.
John and I can see Christina and Kim both nodding furiously in the background as well. Look, thank you for sharing that, and thank you for your advocacy in this area, in the dementia area generally, both you and Scott. I do want to turn back, I know we've only got 5 minutes to go in the webinar, but just to finish our discussion, to refer back to our two experts, real experts in the room, Scott and John. And I'll ask Scott perhaps first. If you had one piece of advice, Scott, for our webinar audience today, and they're from a wide range of backgrounds, both aged care, but also allied health workers and others, if you had one piece of advice, what would it be around the use of allied health?
Oh, have I got an hour to talk?
No, you don't.
Okay. And I suppose I want everyone with dementia and with progressive conditions to get the same professional care I get from my allied health team. So my advice would be that you provide, patient-centered integrated care and supports for your patients, but without having any boundaries. Now, what do I mean by that? I can tell you that Penny, my speech pathologist, has never met Fiona, my physio, that's never met Joanne, my OT, but they're all suggesting different things for me. They don't really care. If it's an OT problem, they go, why don't you go and ask Joanne about that device that helps you get out of the car instead of trying to crawl out like a crocodile. I just think that the allied health people need to care about their own discipline, but also look at patient-centered care for the person and suggest and have no boundaries. That's what I would say.
Thank you. That's a really interesting comment, and I think it's something that's true throughout the whole healthcare sector. That the challenge of providing holistic care, the care that includes the expertise of everybody. And I think again, our dementia advocates have really been pushing for that idea that people who with a diagnosis are also part of that expert team. But that's a really interesting challenge. Scott?
I just answered.
John, sorry, getting to the end of the webinar, I'm running out of brain.
That's
John.
all right, Gary. I was thinking Scott myself, but it's John. Now,
what would you share with us?
Okay, my reflections are these. Okay, you will have noticed from my comments about the modifications to our kitchen and the bathroom that the result reflect what I call, or Glenys and I call, person directed, not person centered, person directed. The fact that I was involved in the entire process ensured that our unit is more enabling and thus has improved my quality of life. These factors are also paramount to consider for all other areas of my life, for example, utilisation of assistive technology. Now, the role of an OT is to assist clients to restore and or to maintain certain capabilities and strengths. A thorough assessment will establish what the person can and cannot do. So please don't fall into the negative mindset that upon diagnosis, a person with dementia immediately loses functionality when engaging in their passions, their interests and their activities and their everyday lives. My philosophy is the more you do for me, the more you take away from me. So avoid instinctively stepping in and do everything for us. Involvement and planning are the key. And I'm hopeful that I can continue living together with Glenys in our wonderful community. Thank you.
Oh, thank you so much for those comments, and I mean I love everything you've said, and but particularly that wonderful line, taken a little, I think, probably from the Montessori approaches to care, that Montessori, yeah, that everything you do for, every time you do for me, you take from me. I think it's such an important thing to have in the back of our minds all of the time. Thank you very much for that. Now, I just want to, I mentioned at the beginning of the webinar that Dementia Australia and Occupational Therapy Australia and Speech Pathology Australia have launched 2 position statements, and we'll just post into chat a link to those position statements. Really, really interesting and important documents. So I really recommend that everybody has a look at those if they can. We've also posted some resources as well. We need to finish now. Look, I want to thank everybody who has put so much work and so much passion and so much time into our webinar today. John Quinn, Scott Cooper, Anita Hobson-Powell for spending, I know how busy everybody is, but thank you, Anita. Kim, Christina, also like to thank the people in the background who I have to say have worked incredibly hard today to get us online and active and chatting. So thank you for overcoming some of those challenges. And thank the audience for spending some of your very valuable time as well. We look forward to catching up with everybody in a couple of months. Again, we will be having a very, very interesting discussion. I'm not going to pass on exactly what we'll be discussing, but we look forward to seeing you again in 2 months. Thank you all very, very much.